I'm Ran Sela, co-founder and CEO of Healium Medical, and we develop ultrasound ablation platform with primary focus on atrial fibrillation. So atrial fibrillation is the most common cardiac arrhythmias. It affects millions around the world. Where you have atrial fibrillation, or AF, electrical triggers originating around the pulmonary veins are causing the atrium to fibrillate. That leads to blood clot formation that can travel to your brain and lead to stroke. And in fact, if you have AF, your stroke risk is 5 times greater. Golden standard procedure for atrial fibrillation is called catheter ablation, in which a catheter is inserted into the left atrium, and then lesions or scar tissue is created around the 4 pulmonary veins to prevent from those triggers getting into the atrium. But to be successful, you need to meet few criteria. It needs to be fully circle, it needs to leave no gap, it needs to be permanent, and it needs to be full thickness. If one of those criteria is not met, the patient will be back to a second procedure. And in fact, what we see that up to 30 or 40% of patients undergoing this procedure will be required to go under a second procedure to complete the isolation. The main failure reason is because lesions didn't meet the ideal criteria, and that leads to electrical reconnection between the pulmonary vein and the atrium. So currently, there are 2 main technological groups that are used for ablation. One is the point-by-point, and the other one is a one-shot balloon-type solution. Even though they differ from one another, they have 3 limitations in common. The first one is that you have to make contact, and a stable contact to ablate. If there is no contact, there is going to be no lesion, and it's not trivial to create a good lesion or good contact because the heart is moving and the patient is breathing, and therefore the lesion is very difficult to create good lesion. It also tends to leave gaps between lesion points, which is very clear with a point-by-point, but even with a one-shot ablation, we can see the anatomy that not all pulmonary veins were created equal. That means that it's very difficult to create circumferential lesion even with a one-shot solution. So that leaves gaps. The third limitation in common, that none of them has any integrated imaging. So you don't know what the lesion thickness is, and you don't know what's happening to the tissue during ablation, so it's basically done based on physician experience and expertise. So our solution is different. We use a different energy modality to create the lesion effectively. We use ultrasound, and our main building blocks of the technology is an ultrasound console, procedure software, transducer motorized unit, and an ablation catheter. The way it works is that we have the ablation catheter, it's connected to a motorized unit. The transducer that emits the energy is surrounded by a balloon just to mechanically position the catheter inside the pulmonary vein, and we have surface electrode to monitor the electrical signal throughout the procedure. Once you're ready to ablate, or once you ablate, our transducer can do 2 things. It can ablate, and it can also image at the same time. So once you're ready to ablate, you get a very collimated acoustic energy to precisely ablate only the tissue of interest. So you connect the transducer into the handle, rotate, and can create either continuous or point-by-point ablation or segmental ablation based on the anatomy. The way it looks in the lab, it's connected bedside, and we can rotate fast for imaging. We can rotate slow for ablation, either step-by-step or continuously. So when we use thermochromatic lesion phantom, you can see how controlled the step-by-step lesions that we create, but obviously we can also rotate it continuously and get a continuous lesion. So in the lab, or in the procedure itself, we insert the catheter over the wire into the pulmonary vein. Basically, we start rotating the transducer, and based on the imaging, the live imaging that we get, we can monitor the distance to the wall and the wall thickness and ablate based on actual tissue parameters. No more guessing or no more relying solely on physician experience and expertise. Ultrasound has also been demonstrated to monitor effectively lesion formations in a publication that was made a few years ago, and we see similar results in our bench testing as well. So the key value proposition that we offer is, one, We don't need to make contact with the tissue to ablate. Ultrasound can just propagate through the fluid or through blood and ablate effectively the tissue. Second, using the motorized unit, we can create continuous lesion. And third of all, we have that integrated imaging to create real-time monitoring. So the way we see the procedure flow, we don't change anything in the way physicians are used to do it today. They insert the catheter over the wire, inflate to position, connect the motor unit to linearly translate the transducer backward while rotating to create the longitudinal and cross-sectional images. Based on these images, we will build the local 3D model. This is the only model physicians need to create pulmonary vein isolation and start ablating, where at every point we'll monitor the exact changes in the tissue to provide a real score of the effective energy delivery until we create a complete circumferential ablation. So by now we have done numerous numerical simulation. We see that we have a good agreement between the thermal profile and the actual lesion that we create. So by this point, we know exactly what's the energy dosage required. We do it in the lab using an XYZ platform that we use. We ablate in multiple locations. Every location, we know exactly how much time, how much energy, what was the changes in the tissue during ablation, and we can do it either focal ablation or continuous ablation by moving the transducer. This was recently presented in the European Heart Rhythm Association and was later published in EP Europace. So when we show this type of images to physicians, they are pretty impressed with the transmurality, with the apparent homogeneity of the lesions. It's very clear where you have been ablating and where you haven't. The company got very nice market traction. We won first place the ICI cardiology conference in Tel Aviv, first place out of 63 companies. So for us, it was like winning the tennis in Wimbledon. A few other competitions, and then in 2022, we won a grant from the European Union, and just recently we were selected for the 2023 Medtech Innovator cohort. It's very difficult to underestimate the market opportunity. More than 1 million procedures per year, more than 2 million newly diagnosed patients every year. So there is no shortage in patient population. There is a shortage in capacity to do effective procedures. And a standalone system that can simplify and streamline the procedure can be very successful in this market. So right now, we are in our development phase. We are looking to complete the development and first-in-human study, raising $7 million to complete those tasks. We have about 50% already committed and looking for a lead investor to join the round. We have been able to leverage on the fact that we are developing a platform technology. We have a collaboration agreement with 2 other strategic companies, one in the renal denervation space and the other in the lung tumor detection. Those agreements give us cross-licensing rights, external funding, and in the future, royalties once it will be commercialized. So the main message is that we are not a one-trick pony company. Our main focus is atrial fibrillation, but it can be used for additional indications as well in the future. So to summarize, we are developing a platform technology, ultrasound platform technology, for rapidly growing markets with large potential and clear unmet clinical need. We have very nice and promising preclinical data, support from KOL and market traction, and believe we can develop the right solution for the right problems. Thank you.